So it ended with the pyogenes. And then we're starting with other Streptococcus bacteria. Again, the Streptococcus genus is huge. There are so many strep bacteria out there. We, again, have to try to sort them. And so we started sorting them based on certain surface antigens that they had. Did they have an A antigen or a B antigen? So there's a group A strep group, there's a group B strep group, and again, there's lots of bacteria just in those. We were looking for strep pyogenes, that's a group A. That's why we had the selective strep A plate looking for it. Again, strep pyogene was not the only thing that's in that strep A group, because you guys saw some growth on your plates. But now we're looking at some of the bacteria that can cause disease that are in the group B of strep. And the first one is Streptococcus agalactiae. Again, at gram-stain's positive, everything in this chapter is positive. How we distinguish it from the group A strep bacteria is that it has a group B antigen on its surface. Again, it's what puts it into this group B strep. When we grow it up on a plate, it does beta hemolysis, but it's a lot smaller. Like strep pyogenes is a group A strep that does beta hemolysis. If you let it grow long enough, that clearing is pretty obvious. It's a lot less obvious with this particular bacteria. Also, what's different between Streptococcus agalactiae and that strep pyogenes that causes strep throat, strep pyogenes was sensitive to bacitracin, which means it didn't grow anywhere near that little bacitracin disc we put on that plate. Whereas Streptococcus agalactiae, because you're like, well, it's got some beta hemolysis to it. On a plate, maybe it's that strep. This particular strep is resistant to bacitracin, which means it would grow right up to that antibiotic disc. So looking at these plates, because there's so many strep out there, looking to see is it sensitive, resistant to certain antibiotics, what is the hemolysis reaction, again, could really help us start to narrow down strep. Won't identify them all the time, but it narrows it down on what it is. Now, why we care so much about Streptococcus agalactiae is for a lot of individuals, normal flora doesn't cause any big issues. However, it is a big issue if mom passes this bacteria on to infants during childbirth. Because for a lot of females, this bacteria is part of their normal flora in the female reproductive tract. And it's just fine there. But if it gets into a newborn, weak immune system, it can cause a lot of issues. So it's then considered a neonatal disease. It can get into the bloodstream and cause bacteremia, it can cause meningitis, it can cause pneumonia, it can cause death. And this happens in about every 3 or 4 out of 1,000 births. It can also cause severe complications, same types of things, in older immunocompromised patients. Diagnosing it, although we can do some of the lab tests, generally we want a faster diagnosis than growing up different plates and looking at different sensitivities. We can do an ELISA test. That again is we can do ELISAs looking for the correct antigen, or we can even look at antibodies that might be present in a particular individual. We do have lots of antibiotics still on the market. It's very treatable, unlike certain bacteria that are becoming resistant. But this is one of the bacteria they do test mom for before childbirth. There's several bacteria they test mom for before childbirth. And then if mom is positive before childbirth, they give antibiotics before childbirth to try to get rid of that bacteria. It may come back later on after childbirth, but the idea is let's get rid of the bacteria right before childbirth just to decrease that chance of passing it on to the infant. Another group of strep are the viridin group. Now, the viridin group are kind of our oddball group because they don't have A antigens. They don't have B antigens. And so we get into they're kind of just oddball. There's another just random group of strep because there's so many strep out there. They're all alpha hemolytic. So on a blood agar, they have that greenish color to it. They're usually part of the human normal flora in their mouths. This is why when you guys did the swabbing of the back of the throats looking for strep pyogenes, and I was like, really good looking example of alpha hemolysis was pretty much on all of your plates. because you probably had some alpha hemolytic strep bacteria growing at the back of your throat, part of your normal flora. The problem is, even though it's part of your normal flora and it's not causing any issues, you didn't even know it was back there living at the back of your throat, is that if it gets somewhere that it shouldn't get, tied to if you're immunocompromised, it can cause a lot of issues. And so it can get into the bloodstream, it can cause endocarditis, it can cause meningitis, it can cause septicemia, causing full organ shutdown. Again, this is if you get a large number of it and you're immunocompromised on top of it. These are some of the bacteria that like to live all over your teeth, which is why even when you did teeth scraping, you probably saw some gram-positive cocci. It definitely could have been one of these strep bacteria. These are the bacteria that as you feed them sugar, they ferment it, they produce acid, and they cause dental caries, which is cavities. Because again, that acid is wearing away your enamel. These are part of the normal flora. They're doing just fine hanging out, but they can cause issues. Again, depending on how immunocompromised, again, generally depends on how bad the issues are. Those that are immunocompromised, elderly, have underlying conditions, because these bacteria are found in your mouths, and because if they get into open wounds, they can cause so many severe issues. People that are immunocompromised, usually before they go in for any kind of dental visit, are usually given a prophylactic antibiotic. The idea is let's make sure you've got antibiotics in your system so that if you're going in there, because you've probably all been at the dentist and they pick away and floss and you got bleeding, that bleeding is now an open wound for bacteria to get in, and if your immune system isn't ready for that, it can cause a lot of issues. So a lot of immunocompromised are given antibiotics before they have any kind of dental treatment. One of the bacteria that's in the viridin group is Streptococcus pneumoniae, and so we've seen Streptococcus pneumoniae in the lab. Again, it's gram-positive, it's cocci, it's part of its name. Usually hanging out in pairs or short chains. Some of you may have seen this when you did your throat cultures, depending on which colony you picked. And again, it lacks those Lancefield antigens. It doesn't have antigens, B antigens, C, D, or F. It's in that viridins kind of oddball group. Now, based on its name, what can it cause? It can cause pneumonia. It is called Streptococcus pneumonia for a reason. However, it's not the only thing it can cause, and it's generally not the most common thing that it can cause. It can cause disease. It can cause lots of different diseases. And part of that is it has a lot of different virulence factors. Again, a virulence factor is something that makes it more likely to cause disease. One of the things that this has, again, they like to hang out in pairs, it has a capsule. That's like its biggest virulence factor, that our immune system doesn't see it right away, it doesn't get rid of it very fast. It also has a protein called adhesin, and based on the name of the protein, that protein helps it stick, specifically to the cells of the respiratory tract. That's usually where it likes to stick first. It also makes an enzyme called secretory IgA protease. Again, it's an enzyme, ends in ase. But what this enzyme does is it destroys antibody A. So even though your immune system is like, okay, you've got antibodies that are trying to target certain bacteria to have your immune system destroy those bacteria, this bacteria makes an enzyme to start destroying our antibodies. Not all of the antibodies, only antibody in the group A of antibodies. It produces a toxin called pneumolysin that breaks apart and destroys epithelial cells. Again, that's where the damage occurs. So it can attach to our respiratory tract, attach to some of those epithelial cells, and then it can also break it down, damaging the body, causing disease. Now, it causes what are known as a whole grouping of different types of pneumococcal diseases. And so when you hear the word pneumococcal pneumonia, because there's vaccines that they're advertised all the time now, for pneumococcal pneumonia, it's nice to be able to break apart words. Pneumonia, although it can cause pneumonia, lots of things can cause pneumonia. Pneumonia, again, we don't consider it a disease because a disease means one thing causes it. And we can go back and say, all right, well, what was the thing that caused that disease? Lots of things can cause pneumonia. It's a condition. It means you've got fluid in the lungs. You've got something going on inside there. Fungus can cause pneumonia. Bacteria can cause pneumonia. Virus can cause pneumonia. Lots of things can cause pneumonia. If we say someone has pneumococcal pneumonia, we're saying it's affecting the lungs. That's part of the word pneumo. But by having that cockle in the name indicates this is a bacteria. Because a cockle is short for describing the coccus shape of the bacteria. So if your patient has pneumococcal pneumonia, they have a bacterial pneumonia. And there's lots of bacteria that can still cause pneumonia, but you know it's going to be a coccus-shaped bacteria. And it's most likely, based on all the bacteria that can cause it, it's most likely one of these Streptococcus pneumoniae. Now, the people that are at highest risk of suffering from more severe pneumonia, elderly, immunocompromised, and infants. Again, we do now have a vaccine against this bacteria, and it's got multiple antigens, and so it's a very effective vaccine, and it's advertised specifically targeting elderly. It's like, hey, have you gotten the new pneumococcal vaccine? I've gotten the new pneumococcal vaccine. You'll see it now that we talk about it, because I've seen it in the last couple months on TV. But again, even though part of its name is pneumonia, it is not the only thing that it causes. Again, it's pretty rare someone suffers, and you'll probably see, unless they're immunocompromised elderly, that you're going to see people that have pneumococcal pneumonia from this bacteria. The most likely or common things that it causes, sinus infections and ear infections. So if you've got a sinus infection or ear infection, because this can get into respiratory tract and it's all combined, your ears and your sinus is all technically part of that respiratory tract and it's all linked, this bacteria can easily get in there. So it can cause pneumonia, rarely. It can get into the bloodstream and it can cause bacteremia or septicemia, and it can cause issues with the heart, it can cause meningitis, all things, all bad, rare. Again, immunocompromised, elderly, underlying conditions. Most likely you'll have patients that have ear infections and sinus infections. Generally, if you have an ear infection or sinus infection, do they identify the bacteria? No, they just give you broad-spectrum antibiotics. This bacteria is very treatable. We've got lots of antibiotics that can treat it. But it causes more of ear infections and sinus infections than anything else. We can gram stain it because it likes to live in the respiratory tract. We usually get a sputum sample. So cough up a big loogie. And culture it out, grow it out. Again, it's Streptococcus pneumoniae. It has alpha hemolysis, and it's sensitive to that antibiotic Optogin. So this is just like a plate we passed around in lab. If we grow it in any kind of media that has bile, bile will dissolve it. And that is something that helps us identify it versus our next group of bacteria we'll talk about. Again, treatment, penicillin seems to be the easiest first one they go for if you're allergic or it's not working, erythromycin. Again, we do have lots of antibiotics to treat it. Prevention, we've got vaccines as well. This is one that they usually are promoting vaccinations. You get them as kids to prevent even ear infections and sinus infections, or decrease. They usually start to say, okay, well, if you're going to college and living in dorms with lots of interactions, you can get one, but usually doesn't cause severe issues unless you're elderly and immunocompromised. Now, getting through the Streptococcus group. So again, they're gram-positive cocci. They all have that coccus word part of the name that tells you their shape. But other than Streptococcus, we do have a group called Enterococcus. Based on its name, entero, where does it live? It lives in the intestines. If we gram stain them, again, they're gram-positive, they're cocci. Again, it's everything in this chapter is gram-positive, and they, based on its name, they're cocci shaped. They also like to hang out in pairs and short chains, just like strep pneumo does. So gram staining can tell us a lot of information. That in itself will not identify bacteria. Although there are multiple Enterococcus bacteria out there, Enterococcus faecalis and Enterococcus faecium are the two Enterococcus bacteria that like to live in the human intestinal tract. And for a lot of individuals, normal flora. This bacteria could easily be in your intestinal tract right now. Not doing anything bad, just hanging out there. In the intestinal tract, it's fine. It's if it gets somewhere else that it causes issues. So it causes opportunistic infections. And if it gets somewhere else, it can cause UTIs. Again, you're not cleaning very well, you're not wiping very well. If it gets in the urinary tract to cause UTIs. If it gets into an open wound, because people don't always wash their hands, and then you got poop on your hands, which means you have bacteria on your hands. If it gets into open wound, it can cause wound infections. It could cause pink eye. There's lots of different things that can cause pink eye. It can get into, and like if you have any kind of cut, or even if you have damage to your intestinal tract, it can cause issues. It can cause septicemia or bacteremia if it gets into the bloodstream. It is a top healthcare associated infection, which means a lot of people pick it up. And not because, oh, like everyone in the hospital is all dirty. It's because of certain procedures if things are not handled, with proper precautions, all the standard precautions. The bacteria is out there and people are having surgeries and they have open wounds, and it's an easy place for bacteria to now get into the body and cause issues. Now, diagnosing it, again, yeah, we could gram stain it. Again, it's be gram-positive, cocci, short chains, great. But how to know it's this versus not, like strep pneumo? One of the biggest things that we can do is we can grow this bacteria on a plate that has bile. Anything that's in the Enterococcus genus can survive in bile. Is there bile in your intestines? Yep. Which means these bacteria have evolved to survive in the presence of bile. Strep pneumo, it lives in the respiratory tract where there is no bile, which means it's never going to grow anywhere with bile. So we can grow these plates, or grow these bacteria on plates in any kind of media that has bile. It's not sensitive to it, so it'll grow. We are having more issues. Anything in the Enterococcus bacteria is becoming more and more resistant to antibiotics. So if patients are picking this up because they had some type of medical procedure, it's getting harder and harder to treat them. Prevention is difficult because it is part of the normal flora, so it's not a bacteria we can just completely get rid of. Its job is to minimize transmission. Good hygiene, washing hands, PPE. We do all of that for a reason, is to keep our patients from getting different diseases while they're in healthcare settings. Now, switching to a completely different shape. So we're done with everything that ends in coccus, and switching to the gram-positive rods or the bacilli. Of all the gram-positive rods that are out there, we divide them into two groups. It's not an even group. Can they make an endospore or not? And as we've hammered this into you already this semester, the two groups are two genus of bacteria that can make endospores, Bacillus and Clostridium, and so we're going to start talking about them first. So the very first genus that can make endospores, so it's gram-positive, it's rod-shaped. Again, they don't like to gram stain well because they can be in an endospore state, are the Bacillus. Now, there are lots of Bacillus species out there. Most of them are environmental, which means they cause no issues with humans. When you guys, if some of you at the very first labs, swab the bottom of your shoes, you probably had a Bacillus. They're really big colonies. It's just found out in soil. It doesn't cause any issues whatsoever. The one Bacillus that does cause issues for humans, so it's the one we talk about, is Bacillus anthracis. And it's not the bacteria that causes the issues, it's the toxin this bacteria makes that causes issues. So Bacillus anthracis makes a toxin called anthrax. Now, there are three ways that you can pick up this bacteria. You can either ingest spores. They can get into the broken skin, so into any type of cut or abrasion, or you can inhale the spores. Depending on how you pick the spores up, depends on what kind of anthrax condition or disease you have. So there's 3 different types of anthrax diseases, again, depending on how you picked it up. The first is gastrointestinal anthrax, which means you ate the spores. Now, gastrointestinal anthrax, super rare. I'd be surprised if you encounter a gastrointestinal anthrax in your careers. You might, though. I had a student, God, it's been probably like 7 years now. I had a student whose brother had this. I gotta remember now, it was like 7 years ago. He was hospitalized for like 4 or 5 months. He survived, but I think they had to fully remove his stomach, part of intestines. Like that toxin just ate him up from the inside. Super rare. Super rare. Even if identified and treated, it still kills about 40% of those, even with treating it, because of the damage that it does. Can be irreversible damage to that gastrointestinal tract. Again, super rare. I'd be surprised if in your careers you encounter it, but maybe. The most common way that people usually pick up anthrax is cutaneous. This particular bacteria, it can be found in animals. Some animals can be carriers of it. It can be found in soil. So if you have an open wound and you're mostly farm animals, interacting with farm animals all the time, gardening, digging in the dirt, it does put you at an increased risk, and this is not a very common disease. But you could suffer what's known as cutaneous anthrax. That anthrax toxin generally doesn't get into the bloodstream and cause death. But because the toxin does destroy, it forms what are known as eschars, or blackened dead areas of tissue that you then have to surgically remove. Still not pleasant. You'll survive. It's not pleasant. That's the most common form of anthrax. Another rare way you can pick it up is you inhale the spores. And this is when you start talking about, there was an anthrax bioterrorism threat. Is that, if you inhale the spores, it's the spores, again, that toxin these bacteria make can destroy your lungs. Because we need our lungs for survival, it can be deadly. Luckily, if you think you've been exposed, you can start taking antibiotics right away and kill the bacteria before they ever start making toxins, and then there's no issues if you know you've been exposed.
Are there any particular animals that are at higher risk of carrying it?
Cows seem to be the top one, which is unfortunately the most predominant animal out there. Again, still pretty rare, but farmers are always at higher risk of picking up lots of different things. And they seem to be the ones that go to the hospital the least often. Now, diagnosing it, we can culture, we can gram stain it, anything in the Bacillus genus. They do have really big colonies. So we can see these really big white colonies. Treatment, we do have lots of antibiotics that can kill it. So it's super treatable if you know you've been exposed. It's treatable. Again, the sooner you can treat, the better, before the toxin starts to destroy tissue. And although we can kill the bacteria, the toxin's still there doing its damage. Prevention is we do have a vaccine that we can give to animals. So a lot of farmers do vaccinate their animals. We can vaccinate ourselves too, but it's pretty rare that you'll probably have it's pretty rare that you'll have an anthrax encounter. So your insurance is not going to allow you just to get vaccinated for it, because you're like, the chances of you actually getting anthrax is like 0.001% or something like that. They're not going to cover it unless you know you're at high risk. If you're like, well, I work in a lab and I work with anthrax. Like, well, I'm a vet and maybe I'm working with lots of animals, that I know aren't vaccinated. Then if you're at high risk, you can get vaccinated. The vaccine we have for humans, it's not the greatest vaccine. It usually requires multiple boosters. Like every year you have to get a booster shot. It just doesn't elicit a lot of antibody response, and then it kind of wanes right away. If animals ever do test positive, they do test animals, they do have to kill them and dispose of them right away. Because again, they could be a carrier to then spread it to other animals. And although it generally doesn't cause as many issues with animals, because of that transmission to humans, we care. Second group of endospore genus-producing bacteria is the Clostridium genus. It's our favorite one. The Clostridium genus, again, they all gram-stain positive. They are bacillus-shaped, and they can make endospores. They are also all anaerobic. So these bacteria are going to thrive only in anaerobic areas in the body, which means they have to get under the skin. They're not going to grow on the surface of skin. They're not generally going to go in the respiratory tract where there's lots of oxygen. There are lots of Clostridium bacteria. We're going to talk about the 4 Clostridium species that cause the most diseases in humans, and you guys already know one. Which one? You guys know it. C. diff. We'll talk about that one. It's not the only Clostridium out there. Some of the diseases you've probably heard of, but you didn't actually know it was a Clostridium bacteria that caused the disease. So there's 4 bacteria in this genus. You gotta know all 4. Like I can guarantee, I already looked at the exam, there's a question on every single one of these 4 bacteria because they are so important, and I guarantee you will encounter patients with at least 2 for sure of these in your future, and then maybe if you're lucky you get a random patient that has 3 or 4 listed. But you will encounter patients that have Clostridium infections. Now, what causes bacteria in the Clostridium genus to cause so many issues is they make enzymes called lipase and protease. Lipase is for lipid or fat, which means they have the ability to break down fats. They can break down lipids. They also make an enzyme protease, which allows them to break down proteins. This allows them to access to lots of nutrients, causing lots of damage to us. The first Clostridium is Clostridium perfringens. And again, it's not the bacteria that causes the issues, as most of these Clostridiums are. It's not the bacteria, it's always the toxins with these bacteria. It's the toxin cause irreversible damage to the body. Depending on how you pick up this bacteria depends on which disease you have. The 2 most common ways is you ingest the bacteria or it gets into an open wound and you don't have a great immune system to get rid of it. If you ingest it, you have food poisoning symptoms. You've got all the vomiting and diarrhea that goes along with your basic food poisoning. Usually don't have a fever, it's just full on, it's food poisoning. Again, our digestive tract knows when it's under attack. If this bacteria gets in the body and starts producing toxins, as that toxins are starting to damage the digestive tract's response is, we're under attack, flush it all out. Hence the diarrhea and the vomiting. And I'm like, it's your body's way of like, we're under attack, get rid of whatever is attacking us as fast as possible. Diarrhea. Great. It works out great because the bacteria will then leave with the diarrhea. If you then start taking antidiarrheals, your diarrhea's medicine, it actually is preventing the body's response of getting rid of the bacteria, and you can actually suffer longer complications. Now, that generally doesn't cause any major issues unless you're immunocompromised, and even just basic diarrhea might kill you. But if it can get into an open wound, so underneath the skin into that anaerobic environment, as it really likes to do, and it likes to get into those areas, into those open wounds where you don't have great blood flow, so your extremities, and if you're immunocompromised, low blood flow means low white blood cell response, and it causes necrosis or death, irreversible damage to that tissue. As the bacteria is in that tissue growing, producing toxins, those toxins and enzymes are destroying the tissue, they're breaking apart the lipids, they're breaking apart literally you from the inside out. This is when as it's breaking it down and breaking down those lipids, it produces a very smelly gas. Has anyone ever, I don't know, some of you I know work as CNAs, has anyone had patients that have had this? I was gonna say, I'm like, I haven't, no, I'm glad none of people in my building have it. But from students, they're like, it's so smelly you can walk into a room and just know. It's like tissue death. It's the smell. I mean, again, it's producing a gas which is smelly, and it's death of tissue for this. Now, to diagnose it, we could try to do bacterial counts. And you gotta have high enough counts, either in the sample or in the food sample to say that you have it. If we grow it up on a plate, it does something called a double zone hemolysis, which means, it does a breakdown that's very obvious around the colonies, but then it has almost like a faint like shadow, which is rare. Normally there's a very distinct line and that's it, but it almost has like a bonus outer shadow of the hemolysis, which is rare to see. Treatment, if you have food poisoning, just replace fluids and electrolytes. The diarrhea is your body's response of getting rid of the bacteria, and it will do that through the vomiting and diarrhea. If you have gas gangrene, which is the full destruction of the tissue, now you have to surgically remove any infected tissue and widespread or broad spectrum antibiotics to kill the bacteria. Best prevention, refrigerate foods so the bacteria doesn't multiply and you have less of a chance of picking up that bacteria. And then making sure wounds are cleaned properly, that this bacteria can't possibly get into an open wound. Again, extremities, especially toes with diabetics, this is a huge thing that they need to be worried about. They have very poor blood supply to their extremities, which means if anything gets in there whatsoever, they're at a huge risk of any kind of infection in their extremities, but this one will start to require amputation if it gets bad enough. Our second Clostridium, your oh so favorite Clostridium, is Clostridium difficile. Now, it was a few years ago, I want to say it was like 5-ish years ago. There are so many Clostridium. Again, we're talking about the 4 top ones that are going to cause human disease, but there's so many Clostridiums out there that the microbiology panel of who knows whatever group it is are like, all right, there's so many Clostridiums, we need other ways to start to distinguish them. You know, it's not like with strep, we're like, let's call them A group and B group. So they're like, well, we need to start renaming Clostridiums. And what they wanted to do is they wanted to rename Clostridium based on where these bacteria start to cause issues. Because this bacteria causes issues in the stomachs, they wanted to rename it Peptoclostridium difficile. But the medical facility got involved and they're like, no. Every documentation, and the medical facility has a lot of documentation, everything on the CDC website, everything in the hospitals that talks about this bacteria calls it what? We call it C. diff, which again, you're never supposed to shorten the species, but we do. We call it C. diff. But if we rechanged it and we changed the name to Peptoclostridium difficile, what are we going to have to call it? P. diff. Like, no. There's no way. You cannot change the name to something that starts with a P because it will cost billions of dollars to go through. You're going to have to hire people to comb through every part of documentation to rename it, and people are still not going to call it P. diff. So, you know, whatever microbiology panel that was figuring this out, they're like, okay, fine, we won't call it that. But they still were trying to figure out ways to organize the Clostridiums because there are so many of them that they did rename it. I just don't call it that because it's slowly transitioning, even paperwork-wise, is Clostridioides difficile. Again, there's lots of Clostridiums. And so we started to have like, well, there's Clostridium, and then there's Clostridioides, and they all kind of sound the same. But they renamed it so they could still keep the C. So you'll see as you go into the nursing or surgeon, like as you read stuff about C. diff, sometimes some of the paperwork will say Clostridium, and some of it will say Clostridioides. Again, it's kind of, they're slowly trying to like filter out Clostridium. But it's still, it's still one big huge group of Clostridium, but there's just so many. They've renamed the genus to some Clostridiums and Clostridioides. Just easier to all call them Clostridiums. Now, away from that, so I'm like, just note, it's slowly transitioning just so you're aware of it if you start to see it called Clostridioides. Yes, we know, they've renamed it. For a lot of people, it's part of their intestinal flora, their normal flora. Some of you guys might have this bacteria in your intestinal tract right now, not causing any issues whatsoever. It's an opportunistic pathogen. Not always because it gets somewhere where it's not supposed to, like it's not causing issues, causing UTI. It's because it causes issues if you get rid of your other normal flora. So if something affects your other bacteria in your intestinal tract, these bacteria have free range to grow and divide and grow and divide and grow and divide and produce toxins that are going to damage your intestinal tract. Now, your book even calls this, it can cause minor infections all the way to explosive diarrhea. And I'm like, I like that your book said that, so I had to put it in there. But bacteria is producing toxins, it's damaging the inside of your intestinal wall lining. And so it's called a condition known as pseudomembranous colitis, which just means inflammation of the colon. And we can see all of the red. That is full damage to your intestinal tract. I mean, it's going to be very painful. And again, when your body's under attack, your intestinal tract, hence the diarrhea, your body's like trying to get rid of the bacteria because you are damaging that intestinal tract. Again, that intestinal tract, there's tons of bacteria in your intestinal tract that now almost have like free range to cause even more issues. But it's causing damage, and depending on how much damage it can cause, it may require removal of some sections of the intestinal tract, depending on the damage. It is considered a nosocomial or a healthcare-associated pathogen. And not because people are just picking up the bacteria in a healthcare setting. They could. If it's not part of your normal flora, and now it is part of your normal flora, you can pick it up. But because the top reason that C. diff grows uncontrolled is antibiotic use, broad-spectrum antibiotics, a lot of people suffer C. diff infections after they've gone to the doctor and were given a broad-spectrum antibiotic for an ear infection or a sinus infection. And although that broad-spectrum antibiotic killed the bacteria that caused that sinus infection, killed other good bacteria too. These are Clostridium, they're harder to kill, they make endospores, they start to grow uncontrolled and cause issues. Now, diagnosing it, we can isolate it from feces, we can grow it in a lab, I wouldn't want to. We can look for the toxins. So we can do an immunoassay that's like an ELISA. We can identify the actual antigens of the toxins. More common now, because it's faster, is PCR, which is looking directly for the DNA of this bacteria to know that it's present. Treatment. It's one of the few treatments for a bacteria. Normally, if you have a bacterial infection, you take an antibiotic. This is one of those few things. If you have a bacteria, stop taking antibiotics. Try to get your normal flora back. The faster you can get your regular normal flora to keep this bacteria in check, the better. We do have, though, depending on how bad the infection is, that might be like, okay, we can't just wait for your normal flora to colonize. We need to kill this bacteria. Metronidazole is our top antibiotic. It's a very strong antibiotic that sometimes the side effects can, amplify the fact that you already have a really bad C. diff infection. So it's not the first thing they do unless they have to. One of the newest treatments is fecal transplant. What does that mean? You're putting someone else's poop in your intestinal tract. This just started maybe 8, 9 years ago. This is a new type of treatment, and it works amazing. Instead of waiting for your normal flora to come back, well, what if we can isolate those bacteria from someone else's fecal matter? It's not like we're just taking a whole bunch of someone's poop and putting it up in there. Where instead, we are taking someone else's poop, we're isolating all those bacteria out. They do this all in a lab, so it's nice and sterile. We isolate all those bacteria out that are part of the normal flora in someone else's fecal matter, and then, yes, suppository, putting those bacteria in your intestinal tract. Those normal flora bacteria will then grow and take hold, and they will keep this bacteria under control. And it works amazing. People that were almost on their deathbed because of C. diff infections that were so bad, fecal transplant, literally within 2 days, they were like, oh my God, I'm better. It's amazing. Without any antibiotics, we just use someone else's normal flora bacteria. So it's like we're trying to figure out ways to work it. Now, right away, the insurance company was like, I don't know how to code for this. Is it an organ transplant? What is it? It's not a drug. It's someone else's bacteria. And I actually still don't know what they coded it, but they didn't love it right away because they just don't know how to charge for it. And of course, they have to get their piece of the pie for any kind of new treatment, especially if it works really well. Otherwise, prevention, good hygiene, so that if it's not part of your normal flora, you don't get it. And probiotics, that if you know you are going to take some type of broad-spectrum antibiotic and you are going to kill a lot of your normal flora, eat the yogurt. that says lots of probiotics, billions of probiotic bacteria. Get those normal flora bacteria trying to recolonize as fast as possible. Clostridium. Clostridium botulinum. Again, it's not the bacteria that kills you, it's the toxin that kills you. So it's called intoxication. Is you ingest, I erased it, but you ingest toxins in food. So botulinum, the Clostridium botulinum causes botulism, and it's generally from eating unpreserved foods, not well-preserved foods. Now, how the toxin works and how the toxin can kill you, my little A&P review. Neuromuscular junction. You're like, oh my God, I thought I'd never have to hear those words again. Neuromuscular junction. Here's your neuron. Here's your skeletal muscle. Skeletal, it's striated. To make a skeletal muscle contract, you have to have an action potential. Again, you thought you'd never heard that word again either. You have to have an action potential that travels along the neuron to that axon terminal, the ending. That's right there next to the skeletal muscle. Here's the skeletal muscle. That axon terminal causes these vesicles that have a chemical called acetylcholine to fuse to the outside. That acetylcholine travels across the synaptic cleft. It goes to the skeletal muscle, and I'm not going to all the other things with calcium and the little muscular things to make it. But the acetylcholine then tells your skeletal muscle to contract. What the botulism toxin does is the botulism toxin coats the end of your axon terminal, which means even though your body, your mind, your nervous system is telling your skeletal muscles you need to contract, I'm giving you an action potential to make this happen, the acetylcholine can't fuse. It can't release that the vesicles can't fuse, can't release acetylcholine, and that skeletal muscle never gets the information to contract. So it prevents muscle contractions of your skeletal muscle. Now if you're like, well, if I don't just flex my arms, that's not going to kill you. Your diaphragm is a skeletal muscle. And if your diaphragm can't contract, what happens? You can't breathe, and then you die. It's kind of important. Now, there's 3 ways that we can get this particular bacteria. Again, they eventually can all cause the same outcome. We can eat the toxin, so you're eating food that has the toxin in it. Again, you could cook your food properly and kill the bacteria, but the toxin may still be present. You can ingest the bacteria, which usually for us, we have immune systems that will recognize the bacteria right away and kill it. Infants don't. So if infants eat this bacteria, it can be very deadly. If we eat just the bacteria, it's generally not an issue. But infants, it will kill them. Or it can get into wounds. Now, if we ingest the toxin or ingest the bacteria, and can't get rid of it, which they'll grow and produce toxins, or if it gets into wounds, sorry, a scratchy throat. Some of the first symptoms that you're going to have, usually within about 2 days, again, it's starting to affect skeletal muscles. Right away, some of your smallest muscles will start to be affected, and those are in your eyes. You'll start to get blurry vision. You might have dilated pupils. It may start to affect other body organs, constipation or digestive issues, abdominal pain. These are the things that usually will send you into the doctors, hopefully. And then they're going to start to question you, like, what have you eaten? Oh, I ate grandma's homemade whatever, jelly or whatever she canned. It's one of the top places that it's picked up is improper canning. Now, even if you get into an open wound, those endospores will grow, the toxins they produce will get into the bloodstream and cause all the same issues. As the bacteria are growing, as the toxin's spreading, it will cause more and more damage. So ultimately, it causes damage to all skeletal muscles, but it's the diaphragm affection, that it affects that will eventually kill you. Diagnosing it, first thing we're going to do is, well, what are the symptoms and what have you eaten? Treatment is you're going to get antibodies against the toxin. Although we're going to give you some antibiotics to possibly kill any bacteria that are making it, it's the toxins that are doing the damage. It's the toxins that are preventing your muscles from contracting. Now, best prevention, proper food canning, and no honey to infants. And I'm going to go back to the honey because I was going to say I've got a picture. If you've ever read a label on honey containers, and if you haven't, go home and look. That should be on every honey container you get. Do not give to infants under the age of 2. The reason for it, Clostridium botulinum can survive in honey. Honey is antibiotic. Like, truly, if you were living on your own, nothing, no access to hospitals, if you could find like honey, you could put it on wounds. It's antibiotic. It's great. Everything. Clostridium botulinum can survive in there because it can make endospores, and it will go dormant and stay in honey. Again, it's not in high concentrations, and it's not growing. It's just staying dormant. If we eat honey, you're right, you might actually be eating Clostridium botulinum in that honey, but it's at a low enough dose, and your immune system can recognize it, and our immune system can get rid of the bacteria before they make the toxin. Infants that don't have that strong immune system response, though, might not be able to see that bacteria. They might not be able to get rid of the bacteria, and those bacteria start to reproduce and produce toxins, which can be deadly for infants. So I don't give infants honey. Because botulinum makes a toxin that prevents muscles from contracting, I'm just writing it up here. Clostridium botulinum. I lied, I wanted to write something else. It's the botulism toxin. I can't spell. There's a reason why we take the heart of that word and we put it together, and what do we make? Botox. Guess what Botox is? It's that. It is the botulism toxin. They are isolating it from the bacteria. They are producing that toxin and putting it underneath your skin. What's the purpose of the botulism toxin? Why does it cause issues? It prevents what? Movement of or contraction. It prevents that muscle contraction. You get very obvious wrinkles because your muscles are contracting. Like in my skin, if I contract the muscles in my forehead, my wrinkles show up a whole bunch. If you literally freeze the your skeletal muscles on your face, what it is, it's freezing them, it's preventing your muscles from contraction, your skin relaxes and those wrinkles don't show up as much. Which is why if you ever hear the advertisements for Botox, because there's commercials all the time for Botox, and then they're just like, and if you have any issues with breathing or anything else, please go see your provider. It's because it should, in theory, stay put and shouldn't get into your bloodstream and it shouldn't travel if it's injected correctly right underneath your skin. But if it did get into the bloodstream and it did travel, it could affect the diaphragm, which is why they mention if you have problems breathing after Botox treatments, go to the doctor right away. Now, the last of our Clostridium is Clostridium tetani, and it works differently than Botox. And when I say differently, almost the opposite. Because Clostridium botulinum, Botox, prevents muscles from contraction. Clostridium tetani prevents muscles from relaxing. Again, it's the toxin that causes the issues. So anytime our muscles are contracting, we have that acetylcholine that's like, yes, muscles contract. But we do also have neurons that secrete chemicals that say, okay, we're done contracting, relax now. And it's that the tetanus toxin that prevents that information telling your skeletal muscles to relax, which means your muscles will contract and they won't ever relax. And because our diaphragm is a skeletal muscle, if our diaphragm stays in a permanently contracted state, what will happen? If your diaphragm can't contract, can't breathe, and you die. So that's why tetanus will kill you. Now, diagnosing it, again, it's permanent muscle contraction. And again, some of the very first muscles that become affected are usually the ones in your face because they're smaller muscles, and it causes a condition known as lockjaw. Again, the only reason your mouth opens is that you relax all the muscles in your face. It's the only reason your mouth opens. It's that constant contracting, relaxing. But if you can't relax, you can't open your mouth. And so it's one of the first ones that's usually noticed that it's probably sending. I mean, sometimes you might be like, oh, I got some weird twitching going on, and your skeletal muscles are having some issue going on. Treatment. Again, antibodies against the toxin. It's the toxin that's causing the issues. We need to bind up the toxin as fast as possible. We can give antibiotic drugs to try to kill any bacteria that are there making the toxin. So let's neutralize the toxin, let's kill the bacteria. And then they're still now then going to immunize you to try to make sure your immune system's working as fast as possible. It is one of the easiest preventable things. We don't have a vaccine against Clostridium perfringens. We don't have a vaccine against C. diff. We don't have a vaccine against botulinum, but we do have a vaccine against tetani. It's the tetanus toxoid vaccine. It's part of the DTaP. Now, because so many people do get vaccinated, I find it, I don't want to say unlikely, rare. I anticipate if you were going into nursing, you'll probably maybe 1, maybe 2 patients ever in your career. I know this just happened 8 or 9 years ago. I don't know, it all blends together after a while, before COVID. There was a young man that came in that started having the lockjaw, and they diagnosed him as having tetanus at Gundersen. They had to put him into a full coma. They had to ship in antibodies. Like, our local hospitals don't just have these antibodies on hand. They had to ship in the antibodies. I think that still took a while to get in. He survived, but he was hospitalized for several months. Now, he was Amish. Do they get their vaccines regularly? Most of them do not. And so that puts them at higher risk of picking up this bacteria. The tetanus bacteria, the Clostridium tetani, lives in soil. Where's one of the places that you normally think of when you think of that it lives? On metal. Everyone's like, oh, it's rusty metal. It must have the tetanus bacteria. No, this bacteria is found in soil. But if you have metal that's rusty, it's probably outside, exposed to the elements. And yes, dust, soil is landing on there, which does put it at a higher risk. And if you got cut by something metal, you now have an open wound, anaerobic environment, on something that probably is dirty and has soil on it. So it's not rust specific, it's just anything outside could have the bacteria and get into that open wound. Now I'm going to flip to the other gram-positive rods that don't make endospores. And there's 4 genus: Listeria, Mycoplasma, Corynebacterium, and Mycobacterium. So the first one, the only Listeria that generally causes issues is Listeria monocytogenes. Sometimes, again, we just shorten it to L mono, kind of like C. diff. It's easier. It's gram-positive. It is a bacillus, but they're really short. So this is where we get into that coxobacillus. They're not quite round, but they're like almost. So they're a little short bacilli. We generally pick them up from eating contaminated food and milk. Milk is the top one. I say drink, but milk is the top one. Kind of the big virulence factor is that they are intracellular, which means this bacteria gets inside of our cells. It actually encourages our macrophages, our phagocytes, to eat it, and it just doesn't get broken down by them, what it's supposed to. And it lives inside of the cells. So this is showing an actual picture of a bacteria that's living in the cells. So it can live in macrophages. It can also get inside liver and gallbladder cells. And once it's living in the cell, it's going to do what it does best, and it's going to reproduce. It causes and why it causes issues and why we care. Generally, it's developing fetuses are at the highest risk. This is one of the few bacteria that can cross the placental barrier. That if mom picks it up by eating something or drinking something with this bacteria, it can cross the placental barrier. It can affect a developing fetus, causing stillbirth. It's not good. It's why they always say make sure pregnant women should always make sure they drink pasteurized milk and make sure everything is cooked properly. It can also cause meningitis and septicemia and other issues in immunocompromised. You guys are healthier. You guys could probably eat food and drink stuff that has this bacteria. The worst you're going to get is basic food poisoning type symptoms. So culturing it, we can grow it up. It is a flagellated bacteria. and it's super active, that it has something known as tumbling motility, that if we look at it underneath the microscope, it just likes to spin underneath the microscope. It doesn't really like to zoom around like most bacteria. It just likes to spin. It is treatable. We do have lots of antibiotics that can treat it. But our best bet is just not get in the first place, is avoid certain foods. Again, one of the top foods that it likes to hang out in is milk, which means any dairy product that goes along with it. And this bacteria is not inhibited by cold temperatures. Most bacteria don't like to grow well at cold temperatures. This bacteria could care less about cold temperatures. And so some of the foods that are, anything raw milk, unpasteurized milk, sprouts, certain deli meats, soft cheeses are at higher risk, and smoked seafood, because it hasn't actually been cooked, it's only been smoked, are all high-risk foods. Is avoid all of those. Again, you guys have healthy immune systems. You might get some diarrhea, a headache, nothing too bad, but in elderly, it can be deadly because it can cause meningitis. And in pregnant women, it can cause stillbirths. Our second group, the mycoplasmas, they're the smallest free-living microbes, and these are pleomorphic. Pleomorphic means it can change shape. Reason for that, they don't have a cell wall. They are gram-positive. Genetically, they are a gram-positive organism, but if we tried to gram stain them, they're not going to gram stain correctly. But genetically, they are a gram-positive organism, so they're unique. Because they're also unique, to try to grow them in a lab, they're very picky. They need very specific growth factors. Where they like to grow and cause issues in the human body, respiratory tract, and the urinary tract. So they are a bacteria that can cause pneumonia that we're going to talk about, but they're a bacteria, if it gets in the urinary tract, can cause UTIs. The most common pneumonia that it causes is known as Mycoplasma pneumoniae. Again, it's got the pneumonia in its name, just like Streptococcus. But this doesn't cause a normal pneumonia. Normal pneumonia, you've got fluid in your lungs, you have very difficult breathing, you're probably going into the hospital, severe fever, everything that's going to take you to the hospital right away. This, it's known as atypical pneumonia, or most people know it as walking pneumonia, which means it's not going to cause severe enough symptoms that's generally going to send you to the hospital. It's kind of like, well, right away, you might have a fever, you're tired, kind of more of your respiratory disease. Nothing that would probably even send you. After maybe a couple weeks, you're like, man, this thing is just not going away. Then you usually start to develop a cough that you're not really coughing anything up. Again, it's living in your respiratory tract. It's still causing some damage. Usually it's spread by nasal secretions, and the biggest group that seems to spread it are kids the age of 5 to 15. Again, they are kind of a group. They're not always washing their hands very well after they blow their nose, and they touch everything and touch everyone, and their immune systems might not be as good as they could be. Diagnosing it, and ELISA looking specifically for the antigens. Best prevention, any guess? It's spread by nasal secretions. Well, covering your mouth if you're coughing. Sneezing in your arm, but even that, I don't know, who knows, but then your arm touches. Then you touch your arm later in the day. It's good hygiene. It's nonstop washing your hands. The third group, there's 4 in this last group, is Corynebacterium. They're also pleomorphic. They do have a cell wall, it's thin. Some of you, when you identified your throat bacteria, may have actually identified it down to a Corynebacterium. There's lots of species out there. Again, we only care about the ones that cause disease. So a lot of them are non-pathogenic, normal skin and oral flora, which again is why some of you probably in your lab report 1 identified your bacterium as a Corynebacteria, because I know some of you did. But we don't care about those. We care about the one that can cause severe disease, which is Corynebacterium diphtheriae, which causes the disease diphtheria. Now, when this gets into your into your mouth, into your digestive tract, as it grows and reproduces, it can produce these big pseudomembranes, these growths at the back of the throat. And if they grow large enough, it can obstruct breathing, which then again can be deadly. Diagnosing it is looking at the back of the throat and seeing the pseudomembrane back there. That's pretty easy. Or we can try to grow it up in a lab and identify it. Like I said, it has very specialized media. It also is a very picky grower, and that takes longer. Treatment, it's the toxin that's producing that pseudomembrane to form. So they're going to give you antibodies against the toxin, antitoxin. Or erythromycin, again, we have lots of antibiotics that can kill it. And if that pseudomembrane is large enough, it might require surgery to remove it so you can breathe. Is like, well, let's just not get it in the first place. Get vaccinated. This is for the Corynebacterium diphtheriae. It is the D in the DTaP vaccine. So again, most people predominantly do get vaccinated against this. And as soon as the DTaP vaccine came out, the number of cases plummeted. So I would say unless our anti-vaxxers numbers keep going up, I find it rare unless you are a traveling nurse somewhere, go to another country, or again, we do have lots of Amish and Mennonite around here. You're working with people that are in that unvaccinated groups. Then we have our last Mycobacterium. Again, they are gram-stain, they do gram-stain, or they are technically gram-positive, because again, everything today is. But these are the bacteria that make that mycolic acid in their cell walls, that lipid, so they don't always gram-stain well. So they have to have that acid-fast stain to actually identify them. The minute characteristics about bacteria in this group, again, they're super slow to grow. Most of the time, we put bacteria on a plate, throw in the incubator 24 hours. Arlene yanks them out the next day. Tons of growth all over your plates. These might take 2 weeks in the plates, in the incubator, for us to actually see those colonies. Super slow to grow. If they get eaten by a phagocyte, they don't get broken down by the phagocyte, which means they can survive intracellular. And they're becoming resistant to a lot of antibiotics. The number one Mycobacterium disease that causes issues that you will probably encounter in your careers is Mycobacterium tuberculosis, which causes tuberculosis, more commonly known as TB. It is a pulmonary disease, so it gets into that respiratory tract. Starts to destroy the respiratory tract. It starts to destroy the lungs. And depending on how much destruction takes place, there are 3 types of destruction: primary tuberculosis, secondary or reactivated, and disseminated tuberculosis. Now, tuberculosis in the lungs. So you breathed in some bacteria, it gets in, it gets eaten. But it's an intracellular organism. It doesn't get broken down by our white blood cells, so it's going to do what it does best, and it will start to reproduce inside those macrophages or those big phagocytes. And it will start to reproduce. As more and more cells start to eat the bacteria, and they start to those bacteria reproduce inside of those cells, all of these cells will fuse together. Eventually, the cells will start to die. But it's when you have infected macrophages fusing together, that's called a tubercle. It's a growth. That's where the word comes from, is tuberculosis. So you start to have all of these fused macrophages that are all infected. These bacteria just hiding out inside there, not getting broken down, but now you have these big growths inside the lungs, inside your little microvilli. And again, not microvilli, your little alveoli, which means you're not going to get that oxygen exchange like you're supposed to. You're not going to get the oxygen in, the carbon dioxide out. You're going to have difficulty breathing. Eventually, these cells don't live forever. They do eventually fully die. And as you have got necrosis. And this actually will start to look almost cheese-like, which is why I found this little little cheese-like organism. It starts to break down. It kind of turns a yellowish, almost Swiss cheese look to it. When it starts to spread to other alveoli in the respiratory tract. So when these cells all rupture and they spread to another, you now have secondary or reactivated tuberculosis. So it's not just, a few bacteria, one tubercle, and you're done, is when it starts to now affect other alveoli, and it's never just one tubercle, and they all start to spread to other areas in there. Disseminated is now if the bacteria get into the bloodstream and go elsewhere in the body, they can cause severe issues. Diagnosing it. Well, we can do an acid-fast test, the acid-fast stain, and they're going to appear what color? With an acid-fast stain. Pink. So we can acid-fast stain them, and right away you're like, I've got a mycobacterium based on their symptoms. Done. We identify them. We can culture them. We can grow them in a lab, but that takes a long time. They can do chest x-rays and look for these tubercle growths inside of there. They can do genetics and look for the DNA. One of the most fastest, easier way is the tuberculin skin test. How many of you have had this done already? Like almost every one of you. If you haven't had it done, you will have it done. I'm going to spell the thing wrong. What they're putting in your skin is purified protein derivative. To PPD. Is that they can grow the bacteria up in the lab. They can isolate the bacteria. They can break it down. They can find certain antigens of the bacteria. They inject antigens into your body. It's not the full bacteria. It's antigens of the bacteria. What they're looking for is if you've ever been exposed to it, or even if you have an active infection, which hopefully you don't, but it's a slow bacteria. Maybe you're infected and you just don't see symptoms yet. If you have antibodies in your body, those antibodies are going to see that little protein part of that bacteria, and they're going to have an antibody response right at that skin level. I'm guessing most of you didn't see that when you had your skin test done. But that's a positive reaction of your antibodies reacting to that protein derivative from the bacteria. It's hard to kill. I mean, it's slow to grow. It's really picky. It hides out inside of cells. So it's usually a combination of antibiotics that are given for months. It's not just like a normal sinus infection, 10 days and you're done of antibiotics. It's a lot of antibiotics that are given for long term. Prevention, there is a vaccine. And again, it's not the most effective vaccine, meaning it can have an antibody response, which also then means you would test positive with a skin test if you've been vaccinated. But it wanes. So people that are really high risk can get it, and again, that would require lots of boosters. Otherwise, face masks, because it is spread through respiratory droplets, one of the biggest ways to prevent it. Another one that's super rare, but it's still a mycobacterium, is Mycobacterium leprae, which causes leprosy. This bacteria grows best at 30 degrees Celsius. So it really doesn't like body temperature, so it only likes to grow the best and cause the most issues in the coldest parts of your bodies, aka your extremities, the tip of your nose, your fingertips, your ears. And I'm like, the things that don't like to maintain 37 degrees Celsius very well. And if it grows in those areas, it causes damage to the tissue, which then again can cause amputation of those tissues. My random thing, and you're like, armadillos. Armadillos are a natural carrier of this bacteria. We don't have a lot of those around here, so just don't go play with armadillos in the wild. It is still a relatively rare bacteria, but if you've got people that have traveled and you're like, I don't know, I was petting these armadillos on my vacation, and now I'm having these weird things. Maybe. It is transmitted nasal secretions and open wounds, so if it does get into your nose, it could, be spread nasal secretions. Pretty rare. And then my last, I think it's my last slide. Yep. Mycobacterium avium centralaire, also known as Mycobacterium avium complex, is the most common mycobacterium infection in AIDS patients in the United States. So it's more common than tuberculosis in AIDS patients. Also picked up by contaminated food or water. It can kill any cell in the body that it infects. We can actually see these are cells, and all the dark pink are the bacteria living inside the cells. Because again, they hide out inside of there. It's very deadly for those that are in the AIDS stage of HIV infection. For us, usually our immune system can get rid of it because it's usually pretty rare, or it can cause food poisoning and we get rid of it. Otherwise, a combination of antibiotics for long term. Pretty rare. I don't know if you'll encounter it. And luckily for us, we're getting